Hello everyone, welcome to a new series of videos where I will be discussing the important chest x-rays that are commonly asked to final year undergraduates in their final year MBBS exam. So let us start off by looking at a chest x-ray. This is a normal chest x-ray. So first of all, you are required to know the view of the x-ray. This is a PA view x-ray. And what is the other view that is commonly being utilized or that can be utilized for taking chest x-rays is the AP view, right? So why I have given this sign? Because most of the time it is the PA view that is being utilized for taking x-ray in a standing on an erect posture. It is because most of our patients are mobile, they can walk, and we get a lot of information from a PA view. And in an AP view, we get many false information, like the inspiratory effort of the patient will not be there. As a result, the lungs will be appearing to you as that of a shrunken volume. Then the angles might be very blunt. Then the cardiac silhouette might look very uh, big to you, giving you a false impression of cardiomegaly. So does that mean that we do not use AP view? No, we use AP view in select patients. For example, patients who are bedridden, who cannot stand erect, for a PA view, who are very much sick in an ICU. So for that, those patients, those group of patients, we do the AP view. Otherwise, mostly it is the PA view, and it is usually written at some top corner of the X-ray or maybe at the bottom also. So just by looking at the X-ray, for start off with saying that this is a digital X-ray in PA view, right? And now let us have a systematic approach towards the X-ray and not just directly jump to the diagnosis. It is because it is the approach that the teachers want us to say, and not just the diagnosis, like for example the pleural effusion or consolidation or whatever. So we will start off with airway, bones, then C for cardiac silhouette and the mediastinal shadow, then the diaphragm, E for effusion and F for fields, and of course check for if there is any Ryle's tube or any endotracheal tube, something like that. So the benefit of this system is that you are looking at the lung field at the last of your approach, right? Like this, so you will not miss any subtle finding. For example, the patient is very sick, he is having a endotracheal tube, or maybe he is having some rib erosion, and you are just concentrating on the pleural effusion. Maybe it is a malignant pleural effusion. You can get the idea by seeing a rib erosion, right? So maybe the pleural effusion is due to the enlarged cardiac shadow, enlarged heart, that is there is cardiomegaly, there is DCM, dilated cardiomyopathy, so things like that. So we will look into that, and just this is another normal X-ray to familiarize ourselves with the normal anatomical structures. So one is the trachea dividing into the right main bronchus and the left main bronchus, right main bronchus and the left main bronchus, right? So we need to see that whether the patient during the X-ray procedure is in some rotated state or not. So but for that we need to see this medial end of clavicle and the spinous process, whether they are equidistant from each other. That will give us an idea about the rotation of the patient, and because that will affect our findings. If a patient is very much rotated to some side, so the X-ray exposure will be affected and the findings will get distorted. So that is the first thing you should look into while reading a chest X-ray. The first is the rotation, right? So for rotation, you are looking at the spinous processes and whether they are equidistant from the medial end of the clavicle. Now this will divide into the right main bronchus and the left main bronchus, the area of noted by number 2 is the hilar area. And what are the important structures that you can note at the hilar area is the bronchus, is the bronchi rather, the right main bronchus and the left main bronchus. Then you can have the pulmonary artery, pulmonary vein, and a hilar lymph node. These are the structures that we commonly see or that are present in a hilum at this region, right? So if there is some hilar enlargement, some hilar shadow is very much prominent, so the pathology might be in this anatomical structures. Maybe there is pulmonary artery hypertension. As a result, the pulmonary artery is looking very dilated. Maybe there is sarcoid and there is hilar lymphadenopathy. So things like that, right? So this is the all about the hilum. 3 is the lung field. Definitely these are the lung fields, and you can note that the bronchovascular markings are present in a normal lung up to approximately 2/3 of the lung field. So beyond this, there are hardly any bronchovascular marking. Same for here. So this is just for the normal orientation of an X-ray. So 5 is the diaphragmatic shadow, and you need to see the entire contour of the diaphragm very properly. Right. 4 is that is 4, and 5 is the cardiac silhouette. We will be seeing the structures forming the left heart border and the right heart border, and these are the costophrenic angles, which should be clear, right? And these are the scapula, less important structures, but definitely you should be looking for them. And these are the ribs. So we will see the rib counting eventually in this series, how to count the ribs. And if it is a female patient, there will be a breast breast tissue shadow. That is very obvious. So this is regarding more or less the normal structures. So this is again another X-ray showing you annotated images of the entire anatomy. So you can see that the right lung is having 3 lobes, namely the right upper lobe, the right middle lobe, and the right lower lobe. You see, during examination also, during your clinical examination, you are not getting access much to the lower lobe from the front side. From the front side, you are not getting that much of the access. However, you are getting the right upper lobe and the right middle lobe fully, almost very to a great extent. So this is the horizontal fissure at the level of 4th intercostal space, at the level of the hilum. This is the usual location. Mind you, these are very important points. We will be seeing the X-rays of collapse and consolidation. So these are very important anatomical structures or landmark. So this is the location of the horizontal fissure. This is the oblique fissure. And in the left lung, there is no middle lobe, rather there is left upper lobe and the left lower lobe. And somewhere here is the lingular lobe, It is a part of the left upper lobe. So in the right lung, you have got 3 lobes divided by 2 fissures. In the left lung, you have got 2 lobes divided by 1 oblique fissure. Right. Now the right heart border is formed mainly by the right atrium, right? And the left heart border, as you can see, is mainly formed by the left atrium here, part by the left atrium and the left ventricle, predominal part. And this is the aortic arch or the aortic knuckle. This is the area of pulmonary trunk, also known as pulmonary bay, right? And the shape is actually like this, a bit kind of concave, and this is a convexity outwards. So aortic knob, then this is the pulmonary bay, and now the left heart border. And these are the costophrenic angles. A right diaphragm is slightly above the left one because of the liver, it's very obvious. So these are, and this is the Fundic gas bubble, these are more or less the normal structures that you can see or that you need to see in a PA view chest x-ray. Now, regarding a description of a pathology, do not jump to the diagnosis. I am reiterating this fact that do not jump to the diagnosis of, let's say, right side consolidation or pleural effusion like that. First, you need to describe the chest x-ray. The opacity can be homogeneous or can be heterogeneous, right? That is the basic thing. So you will describe the x-ray like this is a digital chest x-ray in PA view, and then showing the normal airway, the bones are normal, the cardiac cell. So we will be following the ABCDEF approach. And now let's say he has got a pleural effusion, so we will be saying that this x-ray is showing a homogeneous opacity and things like that. So this is a homogeneous and heterogeneous. And now the opacities can lie in two anatomical spaces in the lung, that is either in the alveoli or in the interstitium. These are the two spaces. So let's say these are the alveoli, right? These are your alveoli, alveolar sacs, and interstitium is interspersed between your alveoli, right? They form the network, or they form the ground substance, the framework of the lung, connective tissue, right? So opacity can form either, your opacity can form either here in the alveoli in the form of exudate, secretion, blood, mucus, or maybe in these areas highlighted in red. So this area is that of interstitium. These are the broad two categories of your opacity. And if so, there are gross differences between the opacities. So mostly the alveolar opacities have a lobar or a segmental distribution, right? Lobar or a segmental distribution. And interstitial opacities, they do not respect the lobar or the segmental boundaries. This is an important point. And they are usually, the alveolar opacities are usually fluffy, they have hazy margins, and these have relatively a sharper margin. So these are like fluffy cotton wool like opacities in the alveoli. And interstitial opacities can be of three types. So these types you need to first describe. So we are describing an opacity. If it is you're finding that the opacities are not fluffy, they are not respecting the lobar boundaries, they're having somewhat sharper margins, so you will describe it as interstitial opacity. And they can be reticular, they can be nodular, or a combination of both. There is reticulo-nodular. And in nodular, if the nodules are very small in size, the size is not important, it's a visual impression. So if it is very less, so we will say that it is micronodular or miliary pattern, classically seen in miliary tuberculosis, right? So this is it. And if there is alveolar opacity and the bronchus or the bronchiole, those are clear of any secretion, then we will be seeing air bronchogram. And this is a very important sign that we will be looking when we will be discussing regarding the consolidation. So, and the alveolar opacities, if it is infective or maybe pulmonary edema, they change very rapidly over time with treatment, and they take a lot of time to change, and we will see it eventually in the subsequent x-rays. So in interstitial, we have three kinds of opacity, and from interstitial, we need to separate the opacity from alveolar opacity. And now in x-rays, we do not usually say in the form of lobes, because lobar anatomy is a 3D thing and X-ray is a 2D structure. X-ray is a 2D paper. We are seeing it, and so we cannot really localize, no matter how much we try to, and pinpoint to the lobar location. That will be not appropriate. So we divide the lung into three zones: upper zone, mid zone, and the lower zone. So if there is opacity here, so we will be saying that it is a homogeneous opacity seen in the upper zone of right lung. That is it. We cannot say that it is in the upper lobe or something like that. We need a lateral view. We need two views for that. Of course, in any x-rays of any place, be it bone or anything in orthopedics or something, we need two views to have a 3D orientation of that structure. And so up to maybe 2 to 3 ribs, 2 to 4, and 4 to 4 and beyond. I mean, this is 2 to 3 space, 3 to 6 and beyond. So this is the upper, middle and the lower zone. And in a normal person, in a normal healthy individual, in a PA view, you can see 6 intersecting anterior portion of the ribs at the mid clavicular line. So we will count the ribs also. Let us see how to count. Right, this is an improper X-ray. Let us see this. Right, so first of all, trace the first rib from below upward or from anterior to posterior. This is the first rib. If this is your first rib, then this is your second rib, and this is the anterior portion of the second rib. Now this is the third rib. You can trace it back, right? This is the third rib. This is the fourth rib, fifth. This is the anterior portion, and you see this is the sixth rib. So, and it is intersecting in the mid-clavicular line. So approximately 5 to 7 ribs, anterior portion of the ribs intersecting in the mid-clavicular line is normal, right? And for posterior ribs, it is 8 to 10, and somewhere it is written as 9 to 10, but not less than 7, right? It should be 8 and above. So you see that the posterior part of the ribs, so this is rib number 1, right? This is rib 1, first rib. This is second, third, fourth, fifth, sixth, 7, 8, 9, 10. So there are 10 ribs, posterior portion of the ribs. The posterior ribs are 10 in number in a normal PA view. So these are the information which we will be requiring to interpret pathological x-rays, for example, pleural effusion, consolidation and things like that. So stay tuned for all the x-rays for this next series, and I will be discussing every important x-rays required for your undergraduate final year exams, right? So that was it. Thank you.